First of all, yeah, we are being recorded. Welcome. Big welcome from me as chair. My name's Phil Morgan. I think I've met everybody here, but we have, I think, all our members of staff here. We have 2 new board members here, and we have 1 visitor here, 1 prospective board member here. So if everybody can introduce themselves. The only person I think we're missing at the moment is Jay Ahmed, who I expect will turn up any second now. But if we start with introductions, Alex, would you like to go first, because you just happen to be on my left-hand side?
Yeah. Hi, everyone. I'm Alex Leach. I'm the Chief Officer here at Healthwatch Salford.
Would you like to introduce yourself, Ali, please, Alison?
Yeah, I didn't know whether I was next. Yeah, I'm Ali McLeod. I'm a member of staff. I'm an engagement officer at Healthwatch Salford.
Super. Scarlett?
Hey everyone, I'm Scarlett. I'm the Volunteer and Involvement Officer at Healthwatch Salford.
Jackie?
Hi everyone, I'm a new trustee with Healthwatch Salford.
Welcome. Rimpy?
Hi everyone, I'm Rimpy. I'm a new trustee at Healthwatch Salford.
Nisa? Nope, you're on silent.
Sorry, I'm the
first one.
Hello, yes, so I'm Nisa and I'm a prospective trustee at Salford.
Super. Elise?
Hi everybody, my name's Elise. I'm the Knowledge and Support Officer here at Healthwatch Salford, and I'm taking minutes for the board meeting today.
Thank you. Mark?
Morning everyone, my name's Mark. I'm part of the engagement team at Healthwatch Salford.
Super, thank you. Harry?
Hi, I'm Harry Golby. I'm Deputy Director of Commissioning from the CCG, and I'm here just to speak to one of your items.
Thank you, Harry. And Jay?
Hi, I'm Jay Ahmed. I'm a trustee at Healthwatch Salford.
And just to formally record, we have apologies from Sam Cook, Jackie Lee and Kate Simpson, all to do with pressures of work at the moment. We do have both Harry and Mark will be involved in presentations during this meeting. I intend to go through the agenda as set out and just deal with the other bits and pieces first. First of all, does anybody have any declarations of interest as a board member? I just have one. I'm now on the board of Guinness Care, which is part of my wider obligations as a board member of Guinness Partnership. So I'm on the Guinness Care has no activity at this point in time in Salford whatsoever. Do we have any questions from members of the public, Elise? No. We have the minutes and action log from the last meeting. Is somebody, and that means you, Jay, I think, happy to agree the minutes as a true and correct record?
Yes.
Thank you. Are we happy to agree that, everybody? Says not knowing nods from people who are not necessarily there, but being helpful. On the action log, there are a couple of items which are listed outstanding. The board appraisals have been completed, so I think the action is now also closed or completed as well. And the only one other remaining item on that bit was around the Salford CCG sharing vaccination data. I don't know, Alex, whether we've actually got anything further on that or not.
It was specifically to do with specific data, and I raised the issue with the CCG, and at the time we didn't have I think it was the ethnographic data, was it, in terms of that? So I'm still waiting for that information to come in. Again, when I share that, when they share that, I'll send that across. I did give an update, I think, a couple of months ago about where we were in terms of that position.
Do you want to close that as a matter of outstanding?
We can close that for now, yeah.
Okay, let's close it for now. You'll report back on it separately anyway. Okay, we now move to our first of our presentations or discussions today. Very big welcome to Harry, not just for attending, but also flagging this up as something that we as Healthwatch might want to contribute to. Some very real live issues at the moment, I think, in terms of clinical prioritisation. and it will be an interesting, if not entirely comfortable, discussion to have afterwards with him. So, Harry, over to you, please.
Okay, thanks very much. So thank you for the opportunity to speak at the board today. So like I said, I'm Harry Golby. I'm the Deputy Director of Commissioning from the CCG. So my team has responsibility for commissioning a range of services. And what I'm talking to you today is about primary care services. So that's GP practices. Okay, so that's where we're sort of focusing. So the reason why I'm here is I've been writing a paper that is going to our primary care commissioning committee. So the committee actually meets next Wednesday. It is a meeting in public, and the papers will be published on our website probably in the next day or two. So I will share the link with Alex around where the papers get published, and you'll be able to see the paper if you want to. I completed the equality impact assessment sort of form for the paper, and I asked Alex to kind of cast his eye over it. And during that discussion, he felt it was appropriate for me to get an invite to today's meeting. So that's why I've come here. So I'll just explain sort of what the paper's about generally, and then if if people have questions and things at the end, then we'll go through that. Over the last sort of 12 to 14 months since the start of the pandemic, we have established what we call a number of primary care support services. So our sort of general strategy, as far as possible, was to kind of help protect our GP practices from some of the impact of the pandemic. Now, obviously, that was an impossible thing to achieve, and of course, they've been massively affected. So they've done all the, so it's worth thinking about all the things they've done, which is the same as the rest of us, really. So they've, had to establish the virtual online consultations and all of that, and new change in how they've operated. They had a couple of quiet months, in the first lockdown, but definitely since last summer, the patient demand and the patient needs have kind of ramped back up. And again, we've seen that over several stages, and they've ramped up again in the last few months. Practices have obviously had to do all the infection control, all the PPE stuff. They've had people off because they've had COVID or suspected COVID isolating. They've had all the vaccination program to sort of contribute to. So all our practices in Salford have been open. They've remained open throughout the whole pandemic, which is good news. But part of that was these support services that we established. So the support services that I'm talking about, so there's probably 4 areas that's worth highlighting. So we had what we call a hot COVID service, or we still have a hot COVID service. So that's a service. So if somebody has suspected COVID and they're feeling really unwell, they need to be assessed by a doctor. They need to be assessed by a GP. Now, often that's a virtual assessment, but it could need face-to-face assessment. So rather than exposing practices probably to people with suspected COVID to come into the practice and do face-to-face assessments, what we did was we established a citywide service run by Salford Primary Care Together, where GPs can refer. So the patient might speak to the GP, they'll refer to this service, and then very quickly that patient gets that assessment and whatever onward care they need, oximetry at home or referral to hospital, or maybe it's just advice. So that's the hot service. We also established a cold COVID service. So this was for patients on the shielding list, and essentially it was to support them to continue to shield. Although the national advice was that they should attend hospital or healthcare appointments, we knew that some were reluctant to do that. So there was a kind of home visiting service available, again, that GP practices could refer to. If a patient was on the shielding list, a team would go out and visit that patient, and that team had all, infection control PPE to make sure the patient stayed safe. There've been lots of challenges around blood tests across the city. So for people, a lot of people need regular blood tests, and so that was obviously, that's not something you can do virtually. So it's quite a challenge that. So we established a phlebotomy service, a home visiting phlebotomy service, again for GPs to refer to. And then the fourth area was, you'll know probably about extended access. So this is a national scheme which was originally envisaged around people being able to access a GP outside normal hours and some of the inequalities around access. Fairly early in the pandemic, we switched that extended access capacity. So there wasn't a lot of demand for kind of pre-bookable appointments, a week on Saturday or whatever, that kind of thing. And we switched that capacity, and we used that capacity to support either urgent care demands or the COVID demands. So it was a switch around how we use that capacity. So those are the four sort of main support services that I'm referring to. And like I say, we established them sort of in the heat of the pandemic last year. Now we are planning for, recovery. So obviously we're watching pretty closely what's going on around the new variants, what's happening in Bolton. We'll be watching what happens in the autumn, but the general plan is hopefully, vaccination programs going well, and we'll see sort of the impact of COVID reducing. So we're planning for that recovery. So we need to have a plan for the rest of this year, really, about what happens with those services. We established them in response to the pandemic, but if we're planning for a post-pandemic world, what happens to those services? And a big part of the reason why we're doing this is inevitably the funding. So there is lots of uncertainty around NHS funding, around how it's going to be managed over the next, this financial year that we're in. But generally, we don't expect the same level of funding in our primary care budgets that we had last year. So if we did nothing to these services, we would probably end up with about a £2 million overspend on those primary care budgets. So that's another reason why we need to sort of plan to make changes to those services. So what I've been doing is I've been working through, we've got GP provider board, so kind of consulting with the GPs to do this exercise of clinical prioritization to come up with a series of recommendations that are going next week to Primary Care Commissioning Committee for a decision around what is our plans around these primary care support services. And it's worth making a few comments around that exercise generally. So the first thing is, let's look at it from a financial point of view. Let's say we need to save that. We need to find that £2 million somewhere. So we have to, let's say we're going to spend £2 million less this year than we would have done otherwise. So the first thing, so of course that's going to affect patients. Obviously, those are patient services, so it is going to affect patients. Whether it has a positive or a negative effect, there's going to be some effect on patients. And the discussion I was having with Alex is, some of those patients will have protected characteristics, so it is going to affect inequality. So I don't want to pretend that's not going to be the case. So the other thing is, so this discussion is not really about whether or not patients get care, it's about how that care is provided. So for example, if you catch COVID, you're really unwell, you need to speak to a doctor. So there's no argument about whether that patient needs that care. That's obviously a high priority care, isn't it, for that patient, needs to be provided urgently. The discussion though is about, do we have a specialist service that GPs can refer to, or is that care provided somewhere else in the system? Do you see what I mean? So it's not a, generally this discussion is about how that care is provided, not whether that care is provided. And the final thing is, so we have choices. Lots of our primary care budgets are determined nationally. Lots of the schemes are nationally determined, but there's quite a lot of things we can do locally. we could afford all of these services, but something else would have to give in the primary care budget. So, you know, that's why it's a prioritization. So we do have to have a you know, it's that genuine prioritization around what's the right way to go forward with these services. So where we've got to is, like I say, a paper which will be published next day or so with some recommendations for primary care commissioning committee to make some decisions on. And the recommendations, there's quite a lot of detail behind it, but I guess the main recommendations are in terms of those hot COVID services. So that's for people with suspected COVID. What we're recommending is that it's premature to stand down those services at this point in the year. It's too early, but we need to start agreeing what the plan is. So at some point this year, assuming the pandemic continues to sort of retreat, we need to start planning for that. So we can't afford to continue with those services for the whole of the year, but at some point of the year, we'll plan for alternatives. It's worth noting that, so that's for suspected COVID patients. So at the moment, suspected COVID patients are people who probably got other respiratory conditions. So lots of coughs and colds. At the moment, there's lots of kids with coughs and colds going through that service who would normally be cared for in normal GP practice sort of services. And at the moment, very few of those patients actually prove to be have COVID, if you see what I mean. But you kind of, because of the way that, you know, it's the referral criteria for that service, the clinical sort of identifiers, you get all sorts of other people in that service, as well as the fortunately relatively low numbers at the moment with actual COVID. So that's the first one. So recommend continue for it, but, you know, plan for an alternative at some point in the year. The second one, the cold COVID service. So this was for the shielded patients. So actually, what we did was, when the National Shielding Programme was suspended, we actually stopped that service around the same time. So that was in April. And that was kind of, you know, it's the same message around the pausing of the shielding programme. And again, it's worth noting, so I think we've got about 12,500 people in Salford who listed on the national shielding list. But actually, in terms of this service, it only had about 1,000 patient contacts since it was established last year. It was sort of 10, 20 contacts a week. That was the number. So actually, there's lots of shielding patients who are providing care, who are probably going into their practice or you know, not going through that service. So that service, we will be reporting to Primary Care Commissioning Committee that service has stopped. The phlebotomy service, so that's one we couldn't quite come to a conclusion to. So in terms of finances, it's relatively cheap. That service is only 50,000. In terms of patient contacts, though, it's relatively high. So that's had 5,000 patient contacts since it was established. It's kind of about 70 or 80 contacts a week. What we've said is, so the GPs kind of said that was a medium priority. So if it got to the point it was unaffordable, then they could envisage a situation where that service is decommissioned. Actually, following the discussion with Alex, what I've actually put Alex now in the paper is that, so that's a decision that the CCG has the ability to make, but I've said we should do some patient engagement before we make that decision, because I suspect, I don't know for sure, but I suspect there's probably some kind of regular users of that service, you know, who have used that service quite a bit. So we can probably find out who those patients are, what their experience has been, what, you know, if that service wasn't there, how would that care be provided for them? So we probably, I'm recommending some engagement around that. And then the final area, so which is this extended access. So again, if you remember what I said was we kind of refocused our capacity to the kind of urgent care and the COVID services. And what we are saying is that we probably for the rest of this financial year, that focus will remain in that urgent care and that COVID side of things. But that does mean, actually probably when the COVID hot services stop, that will probably release some capacity. Then we can start to think about, what's the word, pre-bookable kind of scheduled care capacity. And again, what we've recommended is that there's some patient engagement on that. The intention is to to help with address some of our inequalities, but again, that should be informed by, there's a working group going to be established to look at that. But again, that should be informed by patient engagement. So that, I don't know when it will be, if you see what I mean, but let's say certainly by April next year, we have a bit more of a normal extended access service. It's perhaps redesigned so it wasn't like what it was a couple of years ago. And then the final set of recommendations, there's a set of recommendations which all affect income for practices. Now, that's obviously really important for the practices because they're potentially getting less income than they would otherwise have. But quite what that means for individual patients is really difficult to understand because it will depend on how each individual practice responds to that change. So that's where we've got to. That's the recommendations in the paper. Like I say, there are a couple of suggestions that we do some more deeper patient engagement work over the sort of coming months, and I'm sure Healthwatch may be able to play a role in helping us do that. But I was going to stop there in terms of my presentation and see if anyone's got any questions.
Okay, thank you very much for all of that, Harry. Thank you for being so open about things, and thank you for the acknowledgement of the interest in doing patient engagement. I'm sure we'll be able to help if that's helpful to you in turn. Board members, any questions or comments, please?
Can I ask a question, please?
Please, Jackie.
I'm just wondering, so this year, will there be less face-to-face appointments with this new plan in place?
Okay, so very topical subject. You might have seen some stuff in the press last week about this, and actually some national guidance was published on. Well, I won't say it was first published in the Telegraph, and then a few hours later came out to the NHS, but which talks about a change around. So where it talks about, I think the phrase is considering patient preference for what the right type of appointment is for the patient. So for some patients, virtual appointments have been great and the emails, but some absolutely need face-to-face. So we'll see. I think we are going to see an increase in those face-to-face appointments in general practice. So the paper that I'm talking about probably doesn't specifically reference that, but that's part of that context, that those primary care support services have been helping practices relieve some of the pressure and take some of the workload off the practices. Do you see what I mean? So that then they can provide some of that face-to-face care. But yeah, the practices will be working on that, and we're expecting to see a change over some of them have already changed, and some of them will probably change over the next couple of weeks around that mix of face-to-face and virtual.
Okay, thank you.
And just on that one point, Mark, is there anything that's useful to share with Harry now about your report, which we'll be doing very shortly anyway? But rather than have all of that debate without Harry here, is there anything that's particularly worth flagging up on that issue of migration from face-to-face?
I just think that face-to-face is really, really important for some patients. And I think, as I've mentioned in the report, which Harry's had sight of, I believe you've had sight of it, Harry, that patient choice to the people that we spoke to wasn't offered. And in a lot of cases, it was necessary. So people who are hard of hearing and things like that. So it's not just the obvious barriers that people would assume that somebody needs to see a clinician face to face. There's other kind of hidden barriers, like I said, hard of hearing, language barriers, things like that.
Yeah, absolutely. And it's helpful, that report that I have seen from Mark, and it kind of reiterates some of the messages that we've done. It might be worth actually, if you think about extended, I'm trying to apply that issue to my paper. We think about extended access. So originally extended access was designed to address some of the inequalities in access to GP practices. It'll be quite urgent care focused this year, but then we'll transition, if you see what I mean. When it was established, extended access, we weren't in this world of all the virtual and all that. So in terms of how some of those inequalities might be addressed, there may be some of that patient engagement through that extended access program might provide some opportunities to address them. But yeah, no, I recognise the issue that Mark's report refers to.
Okay, thank you for that. Jay, please.
Thank you, Phil. Yeah, thanks, Harry, for that presentation. I think absolutely stepping down the COVID response when appropriate, is absolutely the way to go. Just two questions. You started the presentation by suggesting that it may well be the most vulnerable who are hardest hit by this change, and I'm just wondering if, in the same way that with our COVID response, we had a list already in place, unlike the rest of Greater Manchester, which allowed us to reach some of the more vulnerable people first with the vaccine. And I was wondering if there's any way with our GP practices using perhaps the same list or a version of that list, if there was any way of protecting the most vulnerable in terms of patient care. And in terms of the phlebotomy, a question around that. I understand there's always been a need for mobile phlebotomists, and I understand there's huge pressures in the NHS of finding people who can actually do the phlebotomy. So I'm wondering if there may be a way of bringing in new healthcare professionals to deliver on that mobile phlebotomy, because I know that already within practices, nurses and various other people, even people working at the desk, receptionists, are being trained up to do that. So just a thought. Yeah.
Okay, thanks. So in sort of answer to your first point around the most vulnerable and some of the health inequalities, yeah, the equality impact assessment, in terms of the services that I'm describing, inevitably, well, the people with the greatest need, some of the suffering the health inequalities, those services tend to be targeted at those people. So we know COVID has had a disproportionate effect in some of our communities, so you would expect the COVID service to see a higher number of those kind of people. We know that shielding patients, again, disproportionate effect, they'll be disabled and disabilities. So again, when we talk about those kind of services, what we see in terms of who gets access to these primary care support services, which are citywide services, is a sort of unexplained variation of utilization via GP practices. So actually, which practice you are a member of, some practices tend to refer higher numbers to these services than others. And that seems to kind of, what's the word? Confuse the picture around who uses these services. Do you see what I mean? So we look at it from a practice point of view and then from a patient point of view, and it gets a complicated picture. But absolutely, in terms of the engagement, we do need to make sure, if we have these primary care support services, that they are accessible by those people with the highest level of need. In terms of the phlebotomy issue, yeah, you're right. I can't remember off the top of my head, but the number of blood tests that are done across our city every week is just mind-blowing. I think it's tens of thousands of blood tests. It's and in terms of the workforce pressures, absolutely, and we do need to continue to expand the workforce available to those blood tests. So you're right, in a lot of practices. So sometimes a practice nurse, sometimes it might be a healthcare assistant, sometimes it might be a receptionist, all trained up to do those blood tests. And we probably need to continue to diversify the pool of people doing those blood tests, because that's been a real sort of issue that's come out through the pandemic, not just for primary care, but for secondary care as well, around phlebotomy and blood tests and how we organise blood tests. And it does have a, like I say, I was amazed when I saw the numbers that go through. It is a big issue. Thanks.
Okay, thanks.
Thank you.
Any other questions or comments, board members, Alex, staff?
Hi, Harry. I just wondered, do you have any timescales for the user engagement consultations?
Not at the moment. So the recommendation will be going to Primary Care Commissioning Committee next week, and then if they make that decision, then we'll sort of firm up the plans around that. But I would expect them to sort of, yeah, next few months. There's probably neither of them. There's probably not a great urgency. There's not a massive urgency. We're not proposing a change that happens in the next couple of weeks. Do you see what I mean? There's got a bit of time for them.
Okay, anyone else? I suppose the only comment I'd make is obviously the ability to get more people vaccinated over a period of time will make a bit of difference to when some of these decisions are made. But I suppose it's very relevant here.
So hopefully, well, all of these recommendations we have to keep under review as we see what happens with COVID, don't we? Hopefully the downward trend will continue, and we can push forward on making those recommendations, put them into practice. But you're right, vaccination and the COVID situation will really affect that.
Okay, I think just briefly summing up, I think the points you've already happily accepted around equality impact assessment, patient engagement, and the work done by Mark on his report have all been accepted by you, and I think they're the 3 points we'd probably like to highlight at this stage. Okay. You are very welcome to stay for the rest of the meeting if you wish. It's all public anyway. You can always watch us from afar as well. So you're very welcome to stay, but we understand if you have to go and do other things as well.
I am going to leave. Thank you for the invite, though. Okay.
Thank you very much, Harry.
All right. Thank you, everybody.
Okay, we are back now down to 10 now. Thank you very much, everybody, for the contributions there. And thank you, Alex, for facilitating this. I think it's the kind of debate and discussion we need to be in on at the moment. One of my slight concerns, and this doesn't apply to Harry at all, is that in the expediency of COVID, little things like patient voice and patient engagement to get gently forgotten about, not on purpose, but just because people are being expedient. And I think it's important that we are ensuring that we continue to nudge in the nicest possible way that into the debate and discussions which are taking place now. Okay, we now move on to Chair's report. As you can see, a fair bit of it's taken up with the items on the ICS. But before we move on to that, are there any other issues people want to pick up from my Chair's report? If not, I'll just briefly touch on the ICS issues. And this probably covers the item Alex has listed as well, under item 10, which is the approach from, it's identified by NHS England. The good news is that we've had a discussion with Healthwatch in Greater Manchester with a guy called Warren Heppelet, who leads for what will be the ICS board. And he's made it clear he's happy to have an engagement with the health watchers in Greater Manchester about what our role would be. And the paper that's from NHS England helps identify what that role is. And in addition, what the offer might be from health watchers in Greater Manchester to contribute to the wider issues around public and patient engagement. So that's an ongoing discussion at this point in time. There's no money identified for that at this point in time. I don't think it's quite in their gift to give it, but that's still a live issue that needs to be discussed and debated, both at a Greater Manchester level and more widely at Healthwatch England level as well. The other issue is pleased to report that following various discussions with Alex and I at various boards last week, I can confirm that Healthwatch will have a place on the locality board when it's set up, and we will have a place on the locality program, transition program board as well. And again, that reinforces the point I made at the beginning of this about making sure that public and patient voice are part of this. Our principles still remain that we're making sure that there is a public and patient role in the new ICS structures, and that includes ICS locality, which is local authority level, and neighbourhood, and that there's a Healthwatch role which is identified and funded as well. Any questions on that part of my report or on the later paper that was submitted as paper 10 by Alex? If there's not, can we now move on to Chief Officer's report? Alex.
Thanks, Phil. So just touching on a couple of points within the report. I won't go into it in specific detail, but the first part of the report is that obviously we've implemented the business plan for the year ahead, which was signed off at the last board meeting. So a copy of that report will come to the public element of the board meeting each meeting for a RAG review of where we are in terms of the position of the business plan. At the last board meeting, we obviously reviewed our 3-year strategic priorities as a board. At this point now, we are going to go out for consultation on those priorities, and a finalised version of that 3-year strategic plan will be brought to the next board meeting for sign-off and obviously publication to set our direction of how we're going to achieve those objectives within that plan. So, as we've discussed a little bit already, we're in preparation to publish 2 reports. The work that Mark's done on the digital exclusion work within primary care, which we're going to have a presentation on at the board meeting today, and also the work that Ali has been conducting for us around equipment services in Salford. Both of those reports will include a response to the recommendations from commissioners and providers. So I think that's a very positive step in terms of both reports and the work that we've done around that research and engagement in Salford. And I think, as we had Harriet in the meeting earlier, that the work is being taken on board by professionals within the system, which I think is incredibly important around patient engagement as a whole. Just to pick up that our Speak Up Salford work that Scarlett has been working on has now ceased in terms of the deadline. We've had 3 grant funded applications come into us, and a panel made up of 2 members of our staff team, 1 board member and 1 volunteer will be reviewing those applications and making an assessment in terms of who will get put forward for that funding in line with an agreed framework, which will all be part of that process. We'll also be looking at moving that fund forward and reopening that again shortly, which is something Scarlett will be leading on for us within the organisation. In terms of partnership working, just to give you an update of where we are in terms of that. So we're involved in 3 pieces of partnership working, and those are the Trusted Voices scheme, the Safe for Salford Lived Experiences panel, and the NTA digital toolkit. So they're all 3 key pieces of work that we're involved in or leading on, and all working in terms of a positive approach in terms of partnership working. So really pleased to report back on that. There is specific details within the report to say what elements in terms of progress we're up to in terms of those pieces of project work. Just highlighting some key figures for the period. So we've currently got on record 21 volunteers, and we're in that period we've had an additional 1 volunteer come on board with us, which is really pleasing. They're from Salford University, so going through the induction process with us now. And also we'll be planning for Volunteers Week, which comes at the beginning of January, so you'll see some information about Volunteers Week from us then. So keep posted in terms of the work we're doing around that. And in terms of information signposting and advice cases, we've received 48 cases that have come into us, which Elise leads on. And in terms of website visits, we've had nearly 2,000 website visits within the period. So I think, again, that shows the increase in terms of the quantity of people that are using our service for information, advice and signposting. And then just really to touch on the GM work that we're doing with our Healthwatches in Greater Manchester. So Phil mentioned that we're actively in discussions in relation to the ICS with our sister Healthwatches, and that also we've been involved in a GM piece of work around dentistry. So all our data coming together as a collective 10 Healthwatch to highlight some of the challenges and issues around dentistry in Greater Manchester. So there will be a report published regarding that piece of work that we've carried out collectively. So that's just an overview of that report, and I'm happy to answer any specific questions in terms of the report itself.
Okay, questions? Anybody? Just a quick one for me on dentistry. This has been an ongoing issue for over a year now, access to dental services. It seems to have been exacerbated by COVID, but it's not been the only problem with it. What are our levers to pull on to make sure that people are getting access to dental services?
So I think the issue is that firstly the CCG don't provide dental commissioning within Salford, and I think that's one of the challenges that it's essentially commissioned throughout Greater Manchester. And I think this is an issue across all Healthwatches that, you know, we have to raise that centrally, hence the reason why we've carried out this piece of work in a collaborative of 10 GM Healthwatches. So I think that will be one lever where we've provided some recommendations within that report to highlight some of the issues. Obviously, there are national issues which I think we're all aware of in terms of dentistry, but it's something that it comes back to us at Healthwatch Salford. The majority of our cases, I think over half of our cases, are in relation to dentistry issues, and as within our business plan for the year ahead, this is something that we're specifically looking at as an organisation, not just the access issue, but other issues that are cropping up in terms of that. And Mark's going to be leading a piece of work around that, where we're initially co-producing that work with people who use services, and we've got a focus group in place next week to start that co-production process of what that piece of research will look like for us in Salford, and ensure that there is some impact that we can get out of that piece of work as well.
Great stuff. Anything else from board members? Lisa, anything you would like to take the opportunity to ask as you're with us?
Yes, actually, I just had a question around the Speak Up Salford funds, or the applications that have been made. So you mentioned there was 3 applications. Does that seem like a low number, or was that what you were expecting? And what's the plans with the excess funds for the applications that haven't been made?
Yeah, so I'll answer the first part of the question, then if Scarlett wants to add any additional parts to that question. So I think in terms of the fund, this is the first time we've actually carried out the fund in Salford, and the funding allocation is that we have, as you can see within our business plan, £10,000 for this project itself. You'll have probably seen throughout our social media, our on the ground presence, that this fund has been put out everywhere, and I'm really pleased in terms of the work that both Scarlett and the team have done in terms of sharing the communications around that. I think one of the things that we want to do in terms of getting it out to a far wider reach in terms of organisation is when obviously we have the opportunity to be in a on the ground state in terms of being able to go to places, because obviously we're all virtually working. That'll give us more of an opportunity to work with groups that may have not seen our information through social and through other sources that we've got it. But I think in terms of the work that we've done so far, I'm pleased that we've been able to get this work underway, and that we have had 3 applications that have come through. And Scarlett, I don't know if you want to highlight anything from your perspective as lead on that piece of work.
I think there's challenges with, like you were saying, Alex, not being able to get out on the ground, meeting with different groups. And some of the feedback we've received from groups that we've approached is that some groups don't have the capacity to look at this kind of project for the time being. So that's going to be some of our considerations as we move forward with that.
And then just to answer your second question around when are we going to be restarting that up, and that's a conversation me and Scarlett will be having, looking at some of the learning from the first phase of the recruitment, and then looking at the second phase and how we want to move that forward. But we'll be looking at that in the next month to restart that piece of second round of grant funding. And it's also worth to add here that Scarlett has also produced a video which is now on our YouTube and other channels, really explaining what that project is about. And we also held in the project engagement phase a workshop session for people to come and find out a little bit more about what that funding is about and how they can get involved. So we've put a number of different avenues for organisations to understand what that is about. And also I just want to highlight the work that we're doing with the panel members as well, that we've got a range of people on that panel scoring applications, which I think is a really transparent and a great way of doing something which Scarlett's taken forward for us.
Okay, thank you, Nisa. Are we happy to accept Chief Officer's report and move on now? And now we move on to the remote appointments report, which Mark has been working on. And I thought it was timely to ask Mark to say something earlier in the meeting when Harry was here, because it would have felt very odd not having two conversations should be joined up. Anyway, Mark, do you want to talk about what you've been doing and what you've uncovered?
Yes, of course, yeah. Now, it's been a long time since we heard the phrase death by PowerPoint, so I thought I'd resurrect it, and because we haven't had a PowerPoint for such a long time. So
that's why you co-host, I understand now.
if I can find where it's gone.
Yes, green, I think, isn't it? The green thing in the middle at the bottom.
Yeah, it's trying to find it though. That's the problem. Apologies for this. It's I have had a few technical problems, and it's a bit ironic that I should be talking about digital exclusion when I seem to be digitally excluded myself.
Plan B is to share the presentation with Elise and ask her to share it.
Ah, there it is. It's all right. I just couldn't see it in my window.
Wonderful.
Can you see that, everybody?
Yep.
Right. Okay. So yes, thanks for this. I'm presuming I've got about 10 minutes or so. So I'll try and summarise it as best as I possibly can. So the remote appointments, it's a project we ran earlier this year for a few months, mainly to explore potential inequalities in the shift from face-to-face appointments to telephone appointments, video consultations. Obviously, people being asked not to visit clinical settings and to obviously do it remotely. At the same time as we wanted to look into this, Healthwatch England were doing a national sort of focus on digital exclusion, and they were working with 5 health watchers around the country. And we thought it would be quite a good thing for us to align ourselves a little bit to what they were doing, just that the information that we were gathering from a local perspective could also feed into national work. So what we did was we used a set of questions that Healthwatch England had devised in doing interviews with patients. And the 3 main focus areas or cohorts of patients that we wanted to talk to were those people who were over the age of 65, those people living with a disability, and those people whose first language wasn't English. Now, just a very quick, as an aside, Healthwatch England were focusing on primary care, and those health watchers in their project were looking at 1 or 2 GP surgeries in their practice. We kind of opened the floodgates and we went out to everybody, and we said to everybody across Salford, just come and talk to us about what it's like for you, what it's been like for you over the last sort of 14 months, 12 months with remote appointments in both primary care and secondary care. As well as those 3 main cohorts of patients, we also had some really good feedback from people who had autism, which gave us quite a good insight into the problems that they were facing. So the idea for us to do this was to create a report which was going to comprise of a suite of patient stories to give real-time sort of evidence as to how it's been for people, you know, all the positive things as well as the negative things. But one of the things we did find, it was really, really difficult to reach patients. We actually found that with GDPR and data protection, we couldn't go to people who were operating frontline services and say to them, can you pass us the details of people you think would fit into our cohorts of patients that we want to reach? So we had to think outside the box a little bit. So what we did was we produced over 700 flyers, which were mailed out to GP surgeries across Salford, asking practice managers if they can identify people within their practice list who they may feel are digitally excluded and would be happy to have a chat with us. And we also had some pop-up banners that we popped around vaccination centres. So the 3 main leisure centres who were doing the vaccinations, in the kind of the post-vaccination waiting area for the 15 minutes, we had these prominent Healthwatch pop-up banners that were facing people. So we got a little bit of feedback that came back from that, which is quite good. But the main thing was that we were reliant upon community organisations sharing our message and trying to encourage people that they were in contact with to obviously get in touch with us to have the chat. So all in all, we interviewed about 23 people. It's not a massive number. And obviously, you know, the caveat in our report does indicate this. But we spoke to 5 people over the age of 65, 5 people who had a disability, 5 people whose first language wasn't English, 2 autistic people, and 6 staff who work across health and care. Just to say, out of those 23 people, that some of the people were actually representing other people within their organisations or their peerage as well. So we kind of got a bit of a collective voice from quite a lot. So our findings, one of the main things we found is none of the patients we spoke to actually had experience of video consultation. We didn't believe that anywhere was offering video consultations. We found out to the contrary afterwards that they were, but we was unable to actually get access to speak to those patients who had experienced it. Primary care services told us that they've done a lot over the last 12 months to implement video consultations with training for staff, getting new equipment. Also, obviously, bolstering up their online services, so where people can email their GP and ask questions out of hours, etc., and stuff like that. We also heard from secondary care clinics that it said that they had been using video consultations, but there were a few teething problems that could range from connectivity. So a clinician could be connected to a patient by video call, but the connection might go down, and nobody actually knew whether that was on the clinician side or the patient side. So as a sort of a negative point about that, it can make what could be a 10 or a 15-minute appointment get a lot longer, which would have a knock-on effect to the rest of the appointments list. However, on the flip side, we did hear that some remote appointments, so telephone appointments, had helped in some clinics to reduce referral waiting lists. So historically, where patients would have to go into a clinical setting and see a clinician face-to-face, a lot of these appointments were actually conducted over the telephone, and were able to bring down the waiting list, because obviously it meant that some clinics could see almost twice as many people. So out of our findings, what we tried to do was group them into 5 different themes. And basically what we said was, for privacy, quite a lot of people that we spoke to said it was difficult talking about personal matters over the telephone. So these are people sort of from their own home, and I think there's a couple of stories actually in the report. One from a lady who wanted to talk about a very personal medical problem, but had children around her, and she couldn't find a quiet area of the house to actually talk about the problem. So she had to mask her words when she was speaking to her GP, and felt she didn't really get the story across, or that the GP really understood what she was saying. The sad downside to that person's story was that she said if she actually gets symptoms like that again, until she can go face to face, she's going to manage those herself. And a couple of other people did say it was just a little bit awkward having phone calls with GPs, especially if they're obviously in work time and they're still in the workplace. One of the big things that I mentioned earlier on with Harry's presentation was patient choice. It was overwhelming that everybody we spoke to weren't actually given the option of having a face-to-face appointment. So some people had difficulties, as I mentioned, people who were a little bit hard of hearing, might not actually be deaf, registered deaf, but they are hard of hearing, and they didn't realise when they were talking to me, they were saying they didn't realise how much they actually lip read, and they found these sort of telephone conversations difficult. Confidence. So quite a few patients actually said to us that they didn't really feel confident in what they were being told at the end of the consultation, either from their point of view that they didn't feel that they're given enough information or the right information, or they didn't quite understand what was being said to them. Communications was a big thing as well. So those people, like I mentioned earlier on, hard of hearing, who have difficulty when they're not face to face. There was also issues with interpreters. So deaf BSL people were telling us that using the text appointment system, it wasn't always being picked up by GPs, by the reception staff. So they weren't getting a response, and therefore their confidence with using that service was quite diminished. We also heard from deaf BSL users again with the use of interpreters at hospital settings. Quite alarmingly, they were telling us that it's 50-50 whether an interpreter will actually turn up, even if they did a face-to-face, which it's a slight aside to the actual realms of the digital exclusion project, but it's something that we picked up on nevertheless. And a final kind of theme was awareness, that there were some patients who said to us that they're willing to give it a go, but they just don't know how to learn how to use this technology. They don't know where to go for support or anything like this. So what we did was we formulated 7 recommendations around those 5 themes and shared our report with providers and commissioners. We've had an amazing response, really, really good positive response has come from both the Northern Care Alliance and Salford CCG. So those recommendations that we made around the subject of privacy, we felt that clinicians should actually ask a patient if they're happy to talk with confidence in their home environment, for example, before proceeding with the consultation. And if not, they should feel that they could offer a face-to-face appointment in the surgery, if that's more appropriate. So Salford CCG came back and they've told us that they are going to raise awareness with Salford GP surgeries and share with senior GPs of how to explore and promote this as a best practice. Around choice, we were saying that staff who are the first contact of the patient should be trained to identify those patients really who feel that a face-to-face appointment is more appropriate, and the staff should feel empowered to be able to offer those face-to-face appointments. Salford CCG told us that they're developing a training programme to address such areas as dialect awareness, non-verbal communication and British Sign Language. Around confidence, we said that staff should actually check back with patients at the end of the consultation just to make sure that patients have actually understood what was being said to them, which also opens the door for the patient to ask further questions if they were unsure. Salford CCG responded saying that this should already be carried out as best practice as expected standards of professional bodies such as the GMC or the RCN. The communication, we made 2 recommendations. We did say, and it's something that we do say quite a lot at Healthwatch Salford because it features in lots of projects that we do, that access for deaf BSL patients needs to be improved. Patients also using interpretation services know where to go to for feedback. one of the patient stories that is featured in the report talks about a patient who was very dissatisfied with the interpretation services, but felt she couldn't raise an issue about it because she didn't know where to go. So Salford CCG have told us that they're exploring ways in which patients with British Sign Language as their first language can raise concerns. But they've confirmed that all Salford practices should be familiar with the booking of British Sign Language or a specific language interpreter. And a final theme of awareness, we made 2 recommendations. We felt that commissioners and providers should raise awareness of how patients can engage with healthcare and where they can go to for support. So this is raising awareness of the different types of consultations, so video, telephone, face-to-face, etc. And if patients wanted to explore these opportunities, where can they go to learn how to use this kind of technology? We also said that changes to services need careful consideration to those it's going to affect, and they need to be communicated in a way that's easily understood. A lot of this part of the recommendation came from autistic people who told us that we gained quite a big understanding actually from this, that things need to be communicated in advance in a way that they can understand so that they can accept the changes. Otherwise, services are just going to be met with suspicion and obviously underutilised. Response from Salford CCG was that they told us that they have an extensive social media presence at the moment, but they are exploring new ways to connect with communities. There is an expectation in the Salford Standard. The Salford Standard, by the way, is the contract between Salford GPs and the CCG, and there's an expectation for them to work together to improve patient experience. So we also heard back from the Northern Care Alliance as well, who had a look at our report. And we're very pleased to find that they welcomed the report and that they're already actioning out some of the issues that have been raised in the Meeting Elective Care Needs Across the System programme. But they are going to look to include lessons from the report in regarding the primary care and patient experience in their launch workshop that was being held in April 2021. Now, I haven't actually managed to catch up with them to find out what the outcome of that workshop is, so that's going to be another little task for me to crack on with. So what happens next? Basically, we're going to publish the report in the next day or 2. And the report and findings will be shared with Healthwatch England for them to include as they wish into their national project. We're going to continue to gather feedback and build on the intelligence that we've already got of patients' experience with remote appointments. So we still want to hear from patients, especially those people who have experienced a video call. It's something that I'm quite interested to find out about, because all the anecdotal evidence that's come to me, I haven't actually been able to speak to a patient about it. And we're going to revisit our recommendations later in the year, just to measure really what improvements have been made. So where the CCG and the Northern Care Alliance, for example, have expressed responses in line with our recommendations, we want to be able to go along and see what they've done and perhaps produce an addendum to this report, just to showcase the good things that are happening out there. That was a very, very quick whistle-stop tour. There's probably a couple of little tiny things I've not included, but you can read about those in the report. But does anybody have any questions?
Can we hop off shared screen, please?
Yes, just bear with me. I've got to find these buttons now. There are, right.
Great. Thank you very much for that, Mark. That was a really helpful report, and it's a really good presentation as well. Thank you. Jackie, I think, has a question.
It's not really a question, Mark. I just wanted to give some feedback on a consultation that I had by video, which didn't go too well because the connection was quite bad, and because it was due to a mole on my ear being looked at, she kept asking me to look at the camera to see, but she couldn't see. So it wasn't a very good video consultation. In the end, I had to take a picture and send it to her. But that's just my experience.
Thank you.
To share that.
Now that's actually very similar to what people were telling us as well. And there is a patient story that's in the report and talks about a gentleman who had to take a photograph of his skin condition. Now he's of his later years, so he's quite savvy with his new smartphone that his grandkids have bought him. But he didn't know how he could take pictures, but he just didn't know how to send them on. And he got himself into. I remember talking to him on the phone, and he got himself into a right stew about, I need to send this to my doctor. My doctor said I've got to send it, but I don't know how to do it. And the pharmacist couldn't help. So he was left with a lot of anxiety that the doctor wasn't really understanding what his condition was. So there are technical problems there. It's
Yeah, absolutely.
Anybody else having any questions at all?
Yes, Jay does, and then Lisa. Jay first.
Yeah, I just wanted to ask. It's about that text service for the deaf and BSL community. The responses, I was thinking, automated responses might not be sufficient, but something like, I mean, there clearly is a problem with what's going on if people aren't getting the responses they need in a short time. So I think maybe if they were to look at the system again, maybe try to develop it so that text could be converted to emails, which are more easily manned, perhaps, so that people would get responses. Automated text just simply wouldn't do, I don't think, in that situation. But the other thing is the whole, and it's a brilliant presentation. Thank you so much for it, Mark. I think the whole thing seems to be saying to me that actually, whilst all these things are being implemented within the organizations internally, and the technology and the teams are being brought up to speed, there is a serious issue in bringing up the public to speed into how to use these things, and maybe there needs to be a concerted effort from healthcare and other organizations to try and make that a priority, not just in terms of arming people with the digital tools, but actually to give them the skills necessary to use those tools as well. So, yeah.
Yeah, just with response to the text message for BSL, from what I understand, it's an appointment service. So whereas a deaf BSL user would traditionally go into a surgery and communicate in some form with a person over the desk and say that they needed to see a doctor, there is the option for them to do this via text. So it's like a text to a mobile number of the surgery, and it was that text that was not being responded. And it was different surgeries, different people. So they just didn't have faith in it.
Thanks, Mark.
Okay, thank you for that. And Nisa, please.
Yeah, so I think the report's fantastic. I think it's very timely. We know that Andy Burnham has launched a digital inclusion drive. And interestingly, with his aims, it's for under 25s and over 75s. So I think what's really important with this report is that you're actually focusing on a wider group and starting a bit younger than 75, which I think is a group that people might assume aren't so vulnerable with the technologies that have changed. So I think that's really important to identify. I did think as well, I think even just access to the technology. So I think a really good point, and lots of things in the report I thought were really insightful with, they may know how to use photos and the video function, but actually if you get an email with a link to dial into a call, that suddenly becomes really confusing. And someone in one of the stories was about an email and not knowing how to access email. So that I think made me think about the infrastructure as well. So are we able to reach people who don't really have access to Wi-Fi or readily have frequent access to Wi-Fi? So, things around that, I think maybe we just need to try and consider in longer term, if that's something to identify, that if there is going to be access through video consultations, could it just be a simple call that is through your phone and it's a video function as opposed to an email invite? So I think there are things which hopefully we can then also look at as a wider picture, but I think it's a great start. And I hope actually this work can be shared so that if Andy Burnham's got his inclusion drive, these findings I think will help make a bigger impact really. So yeah, no, really good work.
Thank you, Nissa. Digital poverty was something that I very slightly scratched the surface on, and I think it's a big project in its own right. Actually, one of the patient stories in the report talks about a lady whose first language isn't English, and she lives in a hostel with her teenage son, and she only has mobile data on her phone. And for the anxiety for her to use her mobile data for a video call, and her son wasn't able to access school or things that he needed for school, was so great she'd rather go without the appointment. So I think there is that as well. It's not just the access, like you said, it's the have they got the connectivity, and if they haven't, have they got the funds to pay for the connectivity. I did a little bit of research and looking at how much data, for example, a Zoom call uses. In some cases, it can use up to 2 gigabytes a day. And if you're on a mobile phone contract, some of the telecoms communication companies, they only give you 1 or 2 gigabytes of data anyway a month. So that could almost eat up someone's data very quickly and again, put them into digital poverty.
Okay, thank you very much for questions and answers. And thank you again, Mark, for all the work you've done on this, and look forward to seeing it published and having the report in due course about future impact.
Thank you.
Okay, are we happy to move on? Jackie, is your hand a legacy hand or a new one?
No, it shouldn't be there.
Right, okay. We just move on to the business plan update from Alex now, although I think there's probably limited reporting at this point in the year. But anyway, Alex.
Yeah, just a very quick update on the plan itself. Just one highlight, just to make the board aware of around the impact section of the business plan. That's currently at yellow. Just to highlight, we have introduced the impact toolkit operationally in the team, which is something Elise is leading on. And our first report will be made at the next board meeting to highlight the impacts made throughout all our work within the organisation. So we can track that throughout the year, and you can be assured as board members that we are creating impact throughout all our work that we carry out. So that's the one point I want to highlight within that report. Everything else we are on track with and planning to move forward on.
Okay, any questions or comments? If not, accept that and welcome that and move on. Thank you very much. And our last item, well, first item under any other business is the Memorandum of Understanding. I think this comes from the Adult Advisory Board, Alex.
It does, yes. So this is about collaborative working to support delivery of Salford local adult care approach for all adults within Salford. We're on the board, the Adult Advisory Board, and this is the MOU which goes out to all the organisations that sit on the board to highlight what we want to achieve as a board within this document here. So it's just really for you as board members to have sight of and then confirm if you're happy with the MOU as it stands for us to sign as an organisation. And if there are any questions, concerns or queries, I'm happy to take them back and get any confirmation you would wish on this document.
Okay, I don't have anything. Does anybody else have anything on this? In that case, I think we're happy to adopt it. Sign it as one to partners. Is there any other business under this part of the meeting from anybody, please? If not, just to note the time, the planned time for our next meeting is on Tuesday the 20th at 10 o'clock. I just want to check from board members and prospective board members that that is okay for you. I think after that we will probably have done some thinking about when we will hold future meetings. But before we do that, I can just check whether the 20th of July, that time is acceptable to board members or not. I see a nod from Rimpy. I see a nod 1, 2, 3. Jay, is that okay for you?
Yeah, that's great for me. Thanks.
Okay, so we'll stick with the 20th of July, but we will probably have a discussion sometime soon about times and days of meetings and what's best for people and what may not be best for people. So we'll acknowledge that as an issue and come back to it. I think that concludes the open part of the meeting. I suggest we close